Welcome to IPOPI Hard Talks. My name is Martine Pergent. I am the president of IPOPI, and this is my pleasure to moderate this hard talk. First, let me take a moment to thank our sponsor, Takeda, for making this event possible. With IPOPI Hard Talks, we explore the complexity of our field with the help of two experts, a presenter and a challenger, who will both bring different perspectives. The presenter will give a talk, after which the challenger will open a stimulating debate. The theme today is secondary immune deficiencies, hematological and immunological insights. To engage in this discussion, I am delighted to welcome our presenter today, Dr. Elena Cabezudo from Spain. Dr. Cabezudo, you are a dedicated hematologist at the Catalan Institute of Oncology in Barcelona, specializing in the treatment of multiple myeloma patients. Dr. Cabezudo is a senior author of a recent consensus publication on managing secondary immune deficiency in patients with hematologic neoplasms. And our challenger today is Dr. Nizar Mahlaoui. Dr. Nizar Mahlaoui, you are the chair of our medical advisory panel and a renowned pediatrician specializing in immunohematology at Necker-Enfants Malades Hospital, University Hospital in Paris, France. Welcome, both of you. How will it work? So, Dr. Cabezudo, you will give first the lecture, and then Dr. Mahlaoui, you will share your comments, and together you will discuss and debate this topic. During the presentation and the discussion between our two guests, you, our audience, will be able to send written questions in the question tab. So let's begin. And Dr. Cabezudo, the floor is yours.
So thank you, Martine, for this kind presentation and for the invitation. It's for me an honor to be here. It's the first time that I participate with you in this field. And I think it's, as I've been told, this is going to be different because the topic today is not primary immunodeficiencies, but secondary immunodeficiencies in hematological patients. So I will start by saying that the field of secondary immunodeficiencies, most of our knowledge is coming from the field of primary immunodeficiency. So from that field, we know that hypogammaglobulinemia patients, this is an issue, is a problem. And why is this a problem? Because patients with hypogammaglobulinemia, they have a higher risk of infections. And this is something that as hematologists, we don't like. It impacts in the overall survival of our patients, in the number of hospitalizations, they provoke delays on the treatment administration. So it is a problem, hypogammaglobulinemia. We know from the field of primary immunodeficiencies that they comes with a higher risk of infections. But in secondary immunodeficiencies, also, we are mainly talking about hypogammaglobulinemia. There are other things. There are cellular dysfunction, neutropenia, and more other problems with our patients. So when we talk about secondary immunodeficiency, as I was telling before, hypogammaglobulinemia, but what else? Because not all the patients with hypogammaglobulinemia will develop an infection. So there must be other factors that we have to take in consideration. And it's not only a matter of the disease, and we know there are diseases in hematology such as chronic lymphocytic leukemia or multiple myeloma, where the secondary immunodeficiency is much more prevalent. But this is something that has to do as well with the treatments. Not all the treatments are the same, so we are adding risk factors to our patients. And with the new treatments that I'm going to talk later, now bispecific antibodies CAR T cells, then it's even worse for them. It's a good news in terms of efficacy, but a worse news is not that good news talking about the risk of infections. And it's something related also to the patient himself, because not all the patients have the same risk. So two patients with the same disease and the same treatment, the prevalence of infections are different. So it has to be with the sex, the age, comorbidities such as renal insufficiency or chronic pulmonary disease that put the patient in a higher risk. And there are also huge spectrum of things that we really don't know very well. Is there any genetic predisposition to suffer from this secondary immunodeficiency and this lymphoma, or is there any pre-existing immunodeficiency that has not been diagnosed before the diagnosis of the hematological neoplasm? So a lot of interrogants to be answered. So talking about the two main diseases, then in hematology, we presents with hypogammaglobulinemia, I would say, is chronic lymphocytic leukemia and multiple myeloma. When we think about chronic lymphocytic leukemia, like 25-30% of our patients presents with hypogammaglobulinemia at diagnosis, and they will develop hypogammaglobulinemia during the course of the disease because of the disease itself and because of the treatments. But it's even worse with multiple myeloma because the rate of hypogammaglobulinemia is even higher. 80% of our patients will have it from the very beginning during the course of the disease, and more now because our treatments in multiple myeloma are until progression, so they are chronic treatments. It's not exactly the same in chronic lymphocytic leukemia, where we have both types of treatments. So the first question that I would like to illustrate here is, can we prevent in any way the infections related to hypogammaglobulinemia? And I would like to present this meta-analysis that was published last year. And as you can see in the first table, the questions that they were asking themselves were, is there any measure that the efficacy of any measure that can diminish the rate of infections, the documented clinical infections? So the first table is about the question of immunoglobulin replacement. They analyzed 5 randomized trials and find that in all of them, in different degrees, but in all of them, there is a benefit in terms of decreasing the rate of documented infections. As you can see here, the average. The second square is to answer the question of whether antibiotic prophylaxis is of any usefulness in this kind of scenario to prevent documented infections. And the answer you can see here, but the answer is no. And if we move to the field of the vaccination, immunization of the patients, then the answer is even clearer. So in favor of immunization. So to summarize this meta-analysis, I have to say, they say prophylactic immunoglobulin reduced the clinical documented infection by 28%. Vaccination is a great measure. It's reduced the risk of infection, documented infections in 63%. Prophylactic antibiotics did not reduce at all the risk, so it's not a great measure, but I will perform more things about this later on. And none of these measures can decrease the mortality rate. Although I have to say that to impact in the overall survival is quite difficult with these trials, because the follow-up has to be long enough to demonstrate benefit in overall survival, and all the rest of variables have to be very controlled. Otherwise, you are not comparing the same. So it's not easy. And I would say that if you can reduce with a measure the documented clinical infections, then is good enough. So the EMA, the European Agency of Medicament, they have clear indications for immunoglobulin replacements in secondary immunodeficiency patients, and it's here. So when you have a patient with a secondary immunodeficiency and he has severe or recurrent infections, or the treatments with antibiotics are not enough efficacious, then you can you can use immunoglobulin replacements. And also for those patients who have an inadequate response to vaccination, or have an IgG level below 0.4 grams per deciliter, so hypoglobulinemia. In all these scenarios, you can use immunoglobulin replacements. Is reimbursed and authorized. And here I would like to present this work that Martine mentioned before. Is It's a work that we started like a couple of years ago and was published last year. So we try to answer the question in Spain, how were we managing the secondary immunodeficiency in our patients? And this survey, it was Delphi survey, was sent to clinical immunologists and clinical hematologists. So they answered half, more or less. And we try to know what was the scenario, the current practice, and to give them, the physicians, recommendations to manage secondary immunodeficiency. So the first thing that I would like to say is that clinical immunologists and hematologists, we both agreed to which patients we should perform a baseline immunological evaluation. So talking about hematology, of course, and they were CLL, multiple myeloma, lymphoma patients, and transplanted patients. So we agreed on the scenario of patients, and then to those patients, we had a half agreement on which should be a baseline immunological evaluation. So for hematologists, it's more simple. So a detailed medical history, physical examination, total protein electrophoresis, and quantification of immunoglobulins were enough for us. And for clinical immunologists, we should add determination of determination of antibodies against the vaccine, so a functional test. We should add immunoglobulin IgG subclasses and immunophenotyping of TB and NK subpopulations when a secondary immunodeficiency is suspected. We mostly agreed, hematologists and immunologists, about the in favor of immunoglobulin supplementation for those patients with recurrent infections, and we agreed on the initial dose that was established on 0.4 grams per kilogram every 4 weeks, and then check the IgG levels every 3 months and maintain the IgG levels above 0.5, between 500 and 700 milligrams per deciliter. So, and to keep going on for at least 12 months when these levels were reached. And we mostly agreed not in favor of antibiotic prophylaxis. So this survey was useful, as I said, to know the scenario and to make some appointments that we should follow. So moving concrete to the concrete scenario of chronic lymphocytic leukemia and multiple myeloma, as I said at the beginning, last year, so I mean several years ago, the treatment was based on classic chemotherapy or immunochemotherapy, where the neutropenia and the cellular T-cell dysfunction were more common. But now we have, I don't know if you know, but if because I'm not sure about the audience, but chronic lymphocytic leukemia, the clonal cell is a B cell. So the B cell compartment is very impaired, because not only because of the clonal cells are there, because of the normal compartment is also quite impaired as well. And we have also adding the toxicity of our treatment. So we have the monoclonal antibodies such as rituximab or inotuzumab, all of them directed against an antigen that is CD20, that is a PAM-B present antibody. Antigen, that is present in all normal mature B cells. So we are like targeting clonal cells, but also normal B cell compartment. And it happens similarly with the BTK inhibitors such as ibrutinib, acalabrutinib, zanubrutinib, that are the ones that we have commercialized in Spain, and I think in whole Europe, more or less. So here we have a BTK inhibition. So as soon as the antigen binds to the receptor, B cell receptor, or the cascade of events is impaired by the BTK inhibition. And same with the BCL2. BCL2 venetoclax is a molecule that restores the pro-apoptotic action of BCL2. So we are targeting our B cells, the normal and the clonal, and we have for sure, we will have hypoglobulinemia. It's very, very frequent, as I said at the beginning. So more than 80% of the patients with CLL will develop hypoglobulinemia during the course of the disease, but not all of them will have problems because of this. So it's probably something we are missing, because not all of our patients with hypoglobulinemia and this kind of treatments are going to have problems of infections. So the ESMO guidelines, the European guidelines for managing and preventing infections in CLL, they establish some criteria how to manage it. And regarding the use of IgG replacement, they recognized that although there is no impact on the overall survival of the patients, as we saw with the meta-analysis that I have presented, it is recommended in all patients with CLL that have hypogammaglobulinemia and recurrent infections or severe infections, even though they are not recurrent. So same as the EMA said. Regarding the antibiotic and antiviral prophylaxis, is not mandatory for all the treatments. It depends on the treatment you are applying to the patients, but it's not mandatory with the treatments that I have shown, the new ones. Fungal prophylaxis is not recommended unless particular cases. And vaccination is universally recommended and as soon as possible. So chronic lymphocytic leukemia is a disease that we don't have necessarily to treat when we diagnose it. So, but in this follow-up period where the patient is coming to our consultation but they don't need any treatment, this is a very excellent moment to vaccinate them, because it's the moment where the hypoglobulinemia is less high, you know. Multiple myeloma is even worse than chronic lymphocytic leukemia, in my opinion. As you can see here in this part of the slide, multiple myeloma, where the clonal cell is plasma cells and the normal plasma cell compartments is also very diminished with the disease. So we have a clear problem of hypogammaglobulinemia from the very beginning. And the risk of infections is well documented, that is much higher than in the normal population. And as you know, multiple myeloma is preceded by a phase of MGAS, of a very small clone of plasma cells that is called MGAS period. So from this very, very beginning, the risk of infections is double than in the general population, as you can see here. And in the case of multiple myeloma, regarding the bacterial infections, the risk is 7-fold higher than in the normal population, and viral infections 10-fold higher than in the normal population. And the infections can be anywhere, but I would say that respiratory infections are at the top one. But anywhere you can see an infection. In myeloma, it's not only a problem of hypogammaglobulinemia, it's a problem of B cell dysfunction, NK dysfunction is a problem of T cell and dendritic cells dysfunction as well. So they are at a higher risk of infections because of the disease itself, but also because of the treatments. So these are like a picture of the treatments that we are using now in multiple myeloma. More or less all of them are here in this slide. So regarding the monoclonal antibodies, same as in chronic lymphocytic leukemias, although the target is different, because we are targeting CD38. There is a PAN, it's expressing all the plasma cells from multiple myeloma, so the levels of CD38 are quite high in multiple myeloma. So it's an easy target. We are targeting this, and we are using proteasome inhibitors or immunomodulators. And with all this, not all, because we are using these treatments from a long time ago, and we are still using them and are the basis of our treatment. But the risk of infections is, the prevalence of infections is around, I would say around 10-20% of our patients will have an infection. But this scenario is much worse when we are moving to the field of the new treatments for multiple myeloma. So CAR T cell is T cell that is engineered in a laboratory to express an antibody in the surface with a viral vector. You introduce an antigen on the surface, so it has the killing activity of a T cell and the specificity to recognize a specific antigen of a B cell. So it's a new technology, or well, new, it's several years by now, but we are start to using it because it's authorized from this year. So we are apart from clinical trials, we are able to use it in the 2024, this year. And bispecific antibodies is something similar, but here you have a pharmaceutical product that is an antibody with dual specificity. It binds to an antigen in the tumoral cell. In most of cases, it's BCMA in the plasma cell clonal. And in the other hand, it binds to the T cell, normally by the CD3. So we have what we know from all these treatments, the new ones, via bispecific antibodies and CAR T cell, is that the hypoglobulinemia is very profound, and they cause neutropenia, lymphopenia, and T and NK disruption as well, in a way that we haven't seen before. And here are the numbers. So for the rate of infections, all these three are bispecific antibodies. So you can see that apart from talquetamab, that is directed to a different antigen in the plasma cell, and the risk of infections is a little bit less. But with anti-BCMA, the risk of infections grade 3 or more are half of our patients will have an infection grade 3 or more. It's a little bit less with CAR T cells. The hypogammaglobulinemia is a little bit less with CAR T cells, and this is due because CAR T cells is a one-shot treatment. So you administer the CAR T cell, and there is a hypoglobulinemia, neutropenia that is profound, but is transitory. With bispecific antibodies, this is a chronic administration where we are administering these treatments every week, every 2 weeks, and every month forever. I mean, forever, or until progression or loss of efficacy, but it's a chronic treatment. So the hypoglobulinemia is really an issue. Neutropenia is worse with CAR T cells, but it's transitory. So here, to summarize the effect of bispecific antibodies on multiple myeloma regarding the risk of infections, here you can see that almost all our patients will have levels of IgG below 200 milligrams per deciliter, especially IgG1, IgG3, that I know that is important for clinical immunologists, these kind of two subclasses. Infections are absolutely very common, mostly universal. So 2/3 of our patients will have an infection, and half of them will have an infection grade 3 or more. Depending on the period we are looking at, if 0 is the time of first administration of the bispecific antibody, you can see here that the main risk at the beginning are bacterial infections, and after these are viral infections and fungal infections. So and after between the first and the third month, viral infections became more frequent than bacterial, and after that, after the third month, then bacterial and virus infections are similar, and the fungal infections are more common at the beginning because of the neutropenia associated with the treatment, but then became less frequent with time. And another thing we have to consider is the risk of CMV reactivation, and where we will have these infections is, I would say, anywhere, but respiratory infections are at the top one, as I said before. The immunoglobulin replacement is very useful in these patients. We know that. You can see here how the IgG, IgA, and IgM levels, and this is the point when we start the administration of a bispecific, and how the levels of IgG decrease until undetectable after the 6th month. Same with IgG, IgM. So we have a very small, very low levels of immunoglobulins. And this is something that is going to happen for sure. So it's not, and we know for sure that they will have infections. So what is recommended here, in difference with other treatments that we applied before and I commented before, is that the use of immunoglobulin replacement is mandatory. And we don't have to start for the patient having an infection. We should replace as soon as the IgG levels fall below 400 milligrams per deciliter. because of this risk of infections. And here you can see where the risk of infections is diminished, or is decreased when you are on IgG replacement or immunoglobulin replacement, sorry, or when you are not. Just a last comment about prophylactic antibiotics. The Spanish, this is done by the Spanish myeloma group. It's a consensus to try to identify those patients with that are at risk of bacterial infection, because it's not so clear, as I said before, the paper of prophylactic antibiotics, but all we know that the respiratory infections are common, and sometimes we would like to use an antibiotic prophylaxis in some cases. So this is just to order a little bit the scenario. So here you can see this, which variables score for increased risk of infections that are mostly related to the tumor bulky and the sex of the patients. Males are at high risk, are the type of immunoglobulin, ECOG, albumin, etc. So the risk can vary between, move between 8% up to 20%. So if we have a patient that falls here in this higher risk and is not well vaccinated, and it's wintertime, and he has a previous history of respiratory infections, so we should start antibiotic prophylaxis at least for these first 3 months where the risk of bacterial infections is higher. This could be a good thing to do to avoid delays on the treatment and putting our patients on risk. So the final recommendation for this myeloma Spanish group, and to summarize a little bit my talk, I would say in the multiple myeloma field, treated with bispecific antibodies and CAR T-cell, that are the treatments that we are going to use very frequently till from now. Immunization is key, is mandatory as soon as possible in the phase, if we are diagnosing our patient in the MGUS phase or in the quiescent myeloma phase, then this is the very good moment. If not, there is most of the cases. As soon as we see him in the outpatients, we can send him to vaccination, and the vaccination against influenza, herpes zoster, SARS-CoV, and pneumococcus are mandatory. To know the serological status of the patient before beginning is important, to know which virus are at risk of being reactivated, quantiferon test to know the risk of TBC reactivation. Antiviral prophylaxis is recommended with cyclovir for all of these treatments and patients. Antifungal prophylaxis depending on the patients, and prophylactic antibiotics according to the risk that I have commented before. And the last one is immunoglobulin replacement for all of them on CAR T-cells and bispecific antibodies with an IgG level below 0.4 grams per deciliter, all of them, before they develop an infection, they should receive immunoglobulin replacement. And I think this was all that I wanted to share with you today. So I don't know if it's okay or not.
Thank you. Thank you so much for that. And now, Dr. Nizar Mahlaoui, your comment?
Well, thank you so much, Elena, for this very nice and thorough overview. I think it's a tour de force. It's really very impressive to have all this bulk of information on several diseases, but also therapies presented to us within such a short amount of time, like 20 minutes. It's really, thank you so much, and it was really nice, and I learned a lot at the personal level. So you're an adult hematologist and oncologist, and you deal with adult patients, and sometimes, I mean, potentially also as well elderly patients. And I was wondering on all these information that you provided us. I think it's really there are many differences between our experience in the field of primary immunodeficiency and the patients who have a secondary immunodeficiency whom you see and manage. So I think one thing that puzzled me, and I think this is also a written question in the chat, that in our experience in the field of primary immunodeficiency, we usually start putting patients under antibiotic prophylaxis. And I know you mentioned it has been reviewed, studied, but it's quite unusual in our field to have adverse results, adverse outcomes. And I was wondering if you could share with us some insights on the reasons that might explain this.
Yeah, because you are telling me that in the field of primary immunodeficiency, all your patients go with antibiotic prophylaxis, mandatory for sure, even when they haven't presented any infections problem at the beginning. Yeah, is that right? I understand correctly?
Not necessarily all patients. I mean, patients who would require, so there would be patients who have, to summarize, obviously it's case by case, but to summarize, patients who have a hypogammaglobulinemia, but not necessarily an agamma, so they have a certain amount of so basically patients who have kind of the same profile as the patients you deal with, but for example, a patient with a CVID with a IgG plasma level of 4.5, for us, we could, and no overt serious infections, we would probably start with Septrin or azithromycin.
Yeah, it's true. And this is something that I have seen that is totally different from a clinical immunologist point of view and our view. Because when we were preparing this work that I shared with you, the Spanish Delphi survey, it was clear that for immunologists, we had the Silvia that the doctor, exactly. So for her, it was very important to have this functional test, because it's clear that the level in secondary immunodeficiency, just the level of immunoglobulin is not enough to predict which patient is going to have a problem with this and which patient are not going to have any infections in their entire life. So, and I read many things in that sense, that for a clinical immunologist to identify which patient with the same low levels of IgG will develop an infection and which is not going to do it. The response to vaccination is very clear. That is, correct me if I'm wrong, is something that gives you a lot of information, and we are not using it because probably we don't know how to use this information. But it's true that in hospitals such as mine, where we don't have any clinical immunologist to comment our patients, we don't look at that. And it's true from the from these randomized trials, these meta-analysis, that even the prophylactic antibiotics didn't show any benefit in terms of reducing the clinical documented infections in secondary immunodeficient patients. We know that there is a problem depending on not only the disease but the treatment. So as I said, the same patient, myeloma, CLL patient treated with classical treatments, the risk of infections because of the hypoglobulinemia is not that high. It is higher at the beginning when the disease is not very well controlled, but it's not that high to advocate for antibiotic prophylaxis for all of them, not taking in consideration the treatment or the comorbidities or other factors. But I don't know. I don't know. So I don't have the answer or why is less frequent the connection between the levels of IgG and the risk of infections in secondary immunodeficiency compared to primary immunodeficiency. Or maybe the risk is the same, but you don't want a child to be at risk and you treat them, all of them. But I don't have this clear answer. Probably we should start doing more functional tests. Do you believe in functional tests? Do you think it's more key that the IgG levels, but then just that, the IgG levels?
Well, yes. When we perform a workup for a patient who has a high degree of suspicion of a primary immunodeficiency, so basically to evaluate the immune functions of the patients, we do serology, post-immunization serology, at least tetanus, sometimes diphtheria, and pneumococcus. But you can also measure other serologies, IgGs and IgMs, such as herpes, Hep B, EBV, CMV, whatever the patients might have developed as an infection before coming to you. Because basically, if a patient had a serious EBV infection or pneumococcal infection and shows no level of antibody, that raises a higher degree of suspicion that the patient has an impaired immune system, that you need to check if it's a secondary or a primary, but at least it shows that there is a big problem. So potentially, if your community of hem-onc and secondary immunodeficiency physicians would be interested in getting some insight on how we do it as a clinical immunologists, we would be happy to build bridges, because I think it's such an important and huge number of patients, and it will be growing, because you mentioned treatments, you mentioned this revolution of CAR T cells, that through papers that came out a few weeks and a few months ago, will also be probably revolutionizing autoimmunity, patients with autoimmune diseases such as lupus, for example. So in a nutshell, they will be more and more broadly available in the years to come. Not mentioning as well that, the targeted therapies, you mentioned ibrutinib. So it's interesting because ibrutinib is a BTK inhibitor used for CLL, and BTK is probably one of the pillar of so the Bruton agammaglobulinemia kinase is one of the pillars of the PID work. So it's patients with under ibrutinib develop adverse infections, and so we create a secondary immunodeficiency through these drugs. So I think, have you ever heard of these kind of collaborations, between PID and SID that have provided, fruitful whatever guidelines or recommendations or clinical trials?
Apart from the one that I presented, that was this work between a clinical immunologist, and so the expert panel we were participating 3-4 clinical hematologists and 1 clinical immunologist. So this was the initiative to collaborate together. But this was to establish a survey and a guidelines. But in a daily practice, really, we unless you work in a hospital where your department of clinical immunology is very beside your door, then it's not so easy. Sometimes I have some patients, but probably adult patients that come to me with primary immunodeficiency, that come to me, very few, fortunately, very few, because it's not really my field. But if I have one, I will email a clinical immunologist to know better what to do, because sometimes I have my doubts. But I think the most similar to what you are seeing in the primary immunodeficiency field are those patients on bispecific antibodies, because they are like severe immunodepressed, and it's an issue, the infections they get, because they don't have gamma globulins. Probably because they are normal, with normal treatments, I mean the treatments we are applying apart from these specific antibodies or CAR T cells, it might have to be with the fact that even we are targeting the clonal compartment and the normal B cell compartment, but there are still some normal B cells all around there with all these immunoglobulins in an adult prepared to fight against infections in a better way than when a patient has a primary immunodeficiency, where the immune system is not as well trained to be able to fight even with the less tools. I don't know if I'm explaining myself, but probably one of the explanations why with such a low levels below 0.4, apart from bispecific, that we know that with these low levels, the infection is going to come for sure. So we have to do something before. But in one of our slides, I was presenting the data with rituximab. The hypoglobulinemia is quite frequent, but the risk of infections is quite low. It's less than 10% of the patients with hypoglobulinemia because of rituximab that develop an infection. So the relation is not so clear than in primary, because probably there is a normal compartment, B-cell compartment, that still works and may be able to bridge all these treatments that we are giving to the patients. I don't know your opinion on that, if it can be this immune system a little bit trained to be able to escape and try to do something, even though the treatments are pushing. It could be an explanation.
That could be an explanation. I think we need to know more. We need to do more research on that, because it's a huge public health issue that is, we're currently facing and we'll be facing a growing issue, especially considering, which is not the point of the topic today, but just mentioning that, IG products, PDMPs, plasma-derived medicinal products, are, very precious products derived from, a source that is scarce and that we need to protect, which is plasma. So I think at a global level, we might face some shortage, even more shortages and more difficult situations. But yeah, just to close this chapter on PDMPs, I think, Martine, you want to say something?
Yeah, maybe I have a naive question, but you mentioned, Elena, that among your patients, you can have PID patients who were not diagnosed and they come to you with an SID. And my question is to both of you. Would it be helpful for you, Elena, to know about underlying PID? And Nizar, would it be interesting to know more about hematological diseases to prevent them in the case of PIDs?
This is a nice question, because I'm not sure of that, because I was reading this national French national registry, the publication. You are an author, Nizar, and I have the data here because I'm write it down. So the number of patients were extremely high. I have 1,375 patients that we followed during a 10 years period, and the risk, I know it is not a question, but the risk of developing an hematological neoplasia was quite low. It was 3.5. So let's go this in the other side. So how likely is that I have an adult patient non-diagnosed of a primary immunodeficiency at this age? So at the age of 40, 50, 60 or 70, that are the median age where we are diagnosis, where 40, no, the median age of diagnosing a myeloma is 65, and CLL is even higher. So they are quite an elderly population. So I wonder, and I think it's a very nice point of discussion, how likely it is that I have this patient non-diagnosed of a primary immunodeficiency. Because to check for that, so to ask for family history, etc., to put this questionnaire that probably you are doing is quite a long time in a consultation, in an outpatient. So I think it is probably useful in certain cases. And it was, for me, I would appreciate if I could, from your point of view, to know which patients it will be interesting to check, because I know not all of them. I don't think we are not going to catch any of these patients with such a low prevalence of hematological neoplasia during the times, 3.5. And so let's see the other side, which patients I should check for to know if they develop this neoplasia because of they had an unknown diagnosed primary immunodeficiency, as Martine mentioned.
Yeah, you're right. If I can jump in and say that what is very interesting from the epidemiological point of view, which basically confirms the knowledge that has been accumulated within the the PID community throughout the years, is that CLL and multiple myeloma are very unlikely to happen in patients with primary immunodeficiencies. So that's one argument. Second is that, as you mentioned, in our cohort of patients in France, I mean, obviously, over 10 years, up to a few percent of patients developed a malignancy, which is basically a B-cell malignancy, DLBCL, for example, or Hodgkin lymphoma, and amongst other malignancies, of course. It's not only restricted to those two. And on the other way around, which I think is kind of close to what you were questioning, is we know that only 1% of the patients with a primary immunodeficiency will be diagnosed because of a malignancy.
Mm-hmm.
But it's really low. So for you, in your cohort of patients, it will be very like a very small niche of patients. But I think it's worth considering that maybe some patients should have a thorough checkup with a clinical immunologist, like hand in hand. And to be honest, I don't have there is no like validated guideline or algorithm. But I think obviously, if you have a very unusual presentation of a malignancy, especially in the young adult, but not necessarily only in young adults, but an unusual presentation, the presence of EBV, Epstein-Barr virus infections, I think it's quite high in found in the samples of the patients. Could be the blood, if you do a PCR, could be also on the tissue, the pathology section. Also, what I think is quite interesting is if you have a young male with, let's say, a lymphoma or a Hodgkin disease, and maybe it could be interesting to look at his EBV status, because it's one of the entry points to an immune dysregulation, primary immunodeficiency, such as XLP or 1 or XLP2, when a male has not seroconverted regarding to EBV, which is a universally distributed virus, and basically 95% of the population has a positive serology. So if the patient has not totally converted, that might suggest an immune deficiency. And obviously, as you mentioned, the family history, but also the personal history. If your patient comes with a series of respiratory infections, unusual skin or gut infections, recurrent warts requiring lots of medical interventions, that could also, lead to a, potentially combined immunodeficiency. And just to mention that here in our hospital, our adult colleagues diagnosed 2 siblings with ADA deficiency. So ADA deficiency in the classical form leads to a severe combined immunodeficiency, which is basically known as a bubble boy disease. So it's really small, young babies. But sometimes some patients might, it's quite rare, right? But it's unusual. But they were you can live a few, maybe until they were diagnosed when they were like 22 years old, and one of the two siblings previously experienced an acute leukemia, and then both of them developed severe and worse. So that's what triggered the search for primary immunodeficiency. So I think, just being open to unusual signs, which I think is what we usually say for rare diseases, is like consider the unusual. But yeah, so that's that would be some insights for you and for your colleagues. And then please also consider genetic investigations, germline, because I think one of the way we see things is we see things more through the prism, the lens of the germline mutations, whereas you are much more competent in your field with somatic mutations, basically, which is a mutation that happens in a group of cells or a cell in later in life and only restricted to this cell population. But I think it's very important to be open-minded.
Yeah, it narrows the scenario a little bit more, because to have a lymphoma, Hodgkin, with Epstein-Barr, that is very common in Hodgkin lymphoma, a young adult male, then it narrows it a little bit, and there are quite good questionnaires that are not, we can give to the patient if we don't want him to answer in our outpatients, that I don't think it takes more than 5 minutes for them to answer, and they can give it them back to us and to know all the family relatives or whatever in the history. And it's true about the germline. Now we are more used to do it in the field of myeloid neoplasms because of the genetic predisposition to myeloid neoplasms. We are starting to check for germline mutation that predisposes to myeloid neoplasms more. So, but it's true that normally we check all the genetic information on the clonal cells. But because of we have some diseases, such as I said, myelodysplastic syndromes or acute leukemia or mastocytosis, that they comes with alterations that can be inherited, then we check a little bit more in germlines. But it's for the last 3 years that we have nurse here that is taking the samples of the skin, the fibroblasts, to do germline mutations in several cases. But it's true that we haven't, it's mostly myeloid neoplasms that we are doing this in the field of hematology, I mean. But yeah.
Can I? Oh yeah, no, okay. So see, if I can ask Elena about what one of the triggers is for primary immunodeficiency is also the toxicity of treatments that are necessary to treat and cure a malignancy, such as some chemotherapies and also sometimes radiation. And when you have a patient who experience unusual side effects, unusual toxicity, would you recommend to look into more detail and maybe look for some specific diseases that might be PID associated with?
Yeah, I remember one case with an unusual toxicity with radiotherapy, and he was a Fanconi anemia, and he was quite, not old, but he was in his 20 or 30s even, so quite, it's not the normal time to, but it's true, the trigger was an unusual pancytopenia after radiation that was absolutely unusual, and this makes us to think if there was something else underlying all these reactions. So we check for, congenital or inherited problems.
For the sake of time, I'd like to answer 2 questions from the tab, and because we come to the end slowly but surely. The first one is, what is the evidence of antibiotic prophylaxis in children with secondary immune deficiency? Have you any answer on that, Elena?
Oh, really? No, because I don't treat children, so I don't have the answer. Maybe Nizar in the...
Yeah. Maybe I can contribute very shortly, because obviously secondary immunodeficiency is quite, it's quite wide, broad. So if we focus on hemonc, I think it's important to remember that patients might experience pneumocystis, and that prophylaxis against this fungus is very important, and it's basically Septrin 3 times a week, at least for the period of time when the child or the teenager has a low lymphocyte count and T-cell count, and that's quite important to remember.
And the other question is quite a nice question for, as a conclusion somehow, would you welcome a future collaboration between immunologists, hematologists, oncologists? And I think can you have your answer. And maybe I can complete the question, what could be this collaboration? What should we address together?
Yeah, I mean, I think it would be a nice, absolutely nice idea, because there are many practices that they do that we haven't incorporated in our daily practice, such as looking for, as I was mentioned, all this stuff. So functional tests, which patients we should check for more, for something underlying the disease, etc. And this is definitely, why not? I think collaboration, so these transversal teams are the future, are here already. But definitely to enrich from the knowledge of the others is perfect for the patients, it's better.
Nizar?
Absolutely concur, and I think we are striving for that, and it will probably spread also knowledge within the adult, because I'm a pediatrician, so I'm trying to also consider the point of view of adult physicians who are doing so much for a large group of patients with very diverse diseases, and that maybe sometimes primary immunodeficiencies are not necessarily acknowledged or thought about when looking for the underlying disease in these patients. So I think it's always a good idea to promote PID and also other groups of diseases, because then, for example, you mentioned another rare disease which is not a PID, Fanconi anemia, but it is absolutely necessary to consider not only for the patient, because it changes the management of the patient, but also for the family screening of the mutation, and also for the offspring, the children of the patient as well. I think it's quite important. So definitely yes.
Okay, with those 2 yes, I think that we come to the end of our hard talks, and I want to thank both of you for discussing this interesting topic with us today, to Dr. Mahlaoui for being such a good challenger, and to Dr. Cabezudo to be very interesting in your talk, in your answer, and also in your questions. We will now also share a short feedback form from which you should pop, it's on the screen right now. So it's very useful for us to know your feedback and to hear your comments to continue to improve this concept. Thanks again to all our attendees for today's edition of IPOPI Hard Talks. In a few days, you will be able to watch them on IPOPI YouTube channel. Don't hesitate to share it as much as you can. And many thanks again to all of you and to our sponsor, Takeda, for making this interesting Hard Talks possible. Thank you.
Thank you, and have a nice
Thank you so much.
Bye-bye.